During this ASH, there have been several presentations alluding to the importance of somatic mutation determination, both for choosing target therapy, and this is something that we will be addressing more and more in the future months. And also, there has been the presentation of the IWG MIPSS molecular, that is a promising system to stratify patients in 6 categories, prognostic categories. Now, we should validate the system. It's a system that has been developed from almost 3,000 cases, and the majority of these cases did not receive therapy, so the results were not influenced by therapy itself, but they showed a high proportion of somatic mutation. Therefore, the fluid system, the continuous system for evaluation of prognostication was developed. And because of this and other systems that have been proposed in the last month, we should be able to validate it also in the setting of transplant. So what is happening now? So if today I have to decide what to do exactly for a patient with MDS, I would try to take into account some mutation whose negative prognostic factors, prognostic weight is known, like TP53, for instance. The biallelic TP53 accompanied by complex karyotype are indeed a negative prognostic factor. We know that even in this case, transplant is not always successful, but still it's a good option for this patient. And the number of mutation is very important. It's a negative factor and should prompt an earlier transplant, in my opinion, because even if the type of mutation is not prognostically so negative, if a patient has 6 or 5 mutation and cytogenetic abnormalities, this is a patient that has a shorter overall survival, and therefore transplant should be really planned earlier. We should validate all the proposed prognostic system, including somatic mutation, because the proposals are very interesting. We have to validate in real life and apply to patients that we see every day in our hospitals.